Good morning, good afternoon, and good evening. I am Professor Judith Ellis, and I'm the current chair of the Tropical Health and Education Trust, and I'm delighted to welcome you all to the 2021 THET Annual Conference. It's our biggest ever conference, where we will together explore and celebrate the power of partnership. In these difficult times, we all search for positives, and one positive we celebrate today is the power of technology, which will, over the 4 days of the conference, allow, with no carbon footprint, more than 400 delegates from over 30 countries and over 65 speakers from every corner of the world to share their experiences and learn from global experts. Some of you will be seeking inspiration to engage in partnership activity. For others who have been part of the Health Partnership community for many years, this is a chance to share, to celebrate what you have achieved or continuously learn from others, and to gain support and encouragement from this motivated global community. At previous conferences, we shared how through global partnership working, we overcame many different challenges, but this year we are certainly a global community. We have all faced the challenge of COVID-19. We could spend many hours debating the rights and wrongs of how governments around the world have responded, but what is undeniable is the resilience and solidarity we have seen from the Health Partnership community. In the first 2 days of the conference, resilience is our focus. Resilience that should fill us all with pride, but also realistic concern for the health and well-being of our health workforce colleagues. Challenges to global health workers have not been restricted to a COVID-19 response or the availability of vaccines. For example, the challenge of providing care in countries with limited resources has become even clearer, with global workforce numbers worryingly low, and many of us have felt powerless as we have heard from our colleagues of their struggles to deliver healthcare in conflict zones. But through it all, we have seen resilience, including the supportive sharing of good practice and innovation. It is certainly time to reflect on the resilience of health professionals as we come to the end of the International Year of the Health and Care Worker. Next Monday and Tuesday, our theme is solidarity, celebrating what working together, strong global partnerships can achieve, but with thoughtful consideration of the tensions inherent in global partnerships, the need to address discrimination or disadvantage due to intersectionality, and consideration of the increasingly challenging global landscape, including the financial challenges facing ongoing partnership activity. Indeed, 2021 has not been an easy year for any of us, but through this conference, I hope you find not only inspiration, but build your own resilience, knowing we all stand in solidarity. Please join me in thanking our sponsors and exhibitors who make this conference possible. Please engage, network, and check out our conference partners in the booths and lounges. Share, seek out the support of colleagues, and for 4 days, immerse yourself in the motivating world of health partnerships. I'm about to introduce some of our superb keynote speakers, and I'm sure you will have many questions for them. Can I please ask you to type your questions in the Q&A box in the right hand of your screens, so that following presentations or in the Q&A sessions, as many questions as possible can be put to speakers. Please also be reassured that low bandwidth options are available if you are struggling with your internet. We will now see a video from Tedros, Dr. Tedros, the World Health Organization's Director General, a good friend of our founder, Eldred Parry, and indeed of THET. Welcome.
Dear colleagues and friends, first, thank you for championing WHO's vaccine equity efforts and for launching the Health Equity for All campaign. The COVID-19 pandemic has taught us all many painful lessons. One of the clearest is that a common threat needs a united, compassionate response. That's why we must vaccinate 40% of the population of all countries by the end of this year and 70% by mid-2022. but we're far from our goal. Countries with the most financial and geopolitical muscle have control of the global supply of vaccines, while the world's poor have been left behind. This is not only epidemiologically self-defeating, it also undermines the global recovery. At the same time, the pandemic has exposed the need for quality health services and systems, even in high-income countries. Investing in quality primary health care can help to address the root causes of disease, promote health in communities, and provide a first line of defense for outbreaks. I thank TED and the partnership community for its support for mobilizing resources and people across health services. We look forward to working closely with TED and all of you to build a healthier, safer, and fairer world. I thank you.
Thank you, Tedros. It is wonderful to have the support of Dr. Tedros. We're now going on to our speakers. And our first speaker of the conference is Professor Chris Whitty, the Chief Medical Officer for England. This gives me the opportunity, on behalf of so many, to thank him for his calm professionalism throughout the pandemic. Professor Whitty knows that and the health partnership community well, and I'm delighted to ask him to open the conference, reflecting on the global challenge facing health workers in this International Year of the Health and Social Care Worker. Dr. Chris Whitty.
Thanks, Judith. Thank you all for being part of this and for inviting me to share with you on this important day. I think that I've been proud to be a healthcare worker really since I started in medicine, but I've never been as proud as I have been over the last 2 years as healthcare workers of all forms around the world have risen to the extraordinary challenges that COVID has thrown at us. And I'll come back to COVID in just a minute. But I do think we should celebrate our colleagues around the world and what they've achieved. For countries where THET works, in addition to that, there have been multiple other challenges, political difficulties, a variety of other issues, which everyone is aware of. And despite that, healthcare workers have concentrated on what is their central aim, which is to improve the health of all their neighbours, citizens, and the wider world. And so I do think we should feel considerable pride in our various professions that make up health. When I look back on THET, since its foundation and initial vision set by Sir Eldred Parry in 1988, what it has demonstrated is not only the importance of mutual learning across nations for healthcare workers, but also it has managed to change the way in which it has done that and what it has concentrated on as time's gone by, as it should do, because health itself changes, the science behind health changes, and also as countries have developed, the need for what is the greatest need in terms of international support also changes. And THET has responded, I think, remarkably well to all of those changes. And I'm extremely admiring of THET's work over that period and now. And many of the things that THET is now doing are areas which are, in a sense, relatively, would be different from what they would have necessarily been concentrating on over in the early years, but are really serious problems ranging from burns to maternal mental health. And these are issues that are absolutely critical to the health of nations as they are developing. Moving to COVID, I think there's a lot pretty obvious points to make about COVID. We have not seen a global pandemic of this scale in our clinical lifetimes. On the other hand, those working in areas highly affected by HIV, Southern Africa, for example, have previously dealt with a very major challenge. And in every health emergency, healthcare workers move towards the challenge rather than away from it. And COVID in every nation has been no exception to this, and it's been very remarkable to see. But they did the same in HIV, they did the same in Ebola in West Africa, and so on. And of course, this makes the work already very difficult work of healthcare workers, particularly in areas of relatively limited resource, even more difficult. The workload goes up overall because of direct effects of COVID, and it has done that around the world at different points because waves go through, but there is virtually no country that's been left untouched by this. There's also the concern, not possibly for healthcare workers' own health, but certainly also for the health of their family and their friends around them. So it's done in a period of stress over a prolonged period. Many people can deal with a stressful period that lasts, a week or two, but over 2 years really can be very tricky. And of course, it's also displaced extremely important activities in healthcare around the world, which still need to be addressed. So there's going to be a long period after COVID where we're catching up on the things we would otherwise have been doing when COVID affected us. So it has created really very substantial difficulties for healthcare workers everywhere. The exact problems have slightly varied around the country, but around the world, but everywhere. But I do think that the healthcare professionals, including all of you in THET, have responded magnificently to that. When we think about mutual benefit by exchange of learning from health around healthcare workers and between different types of healthcare workers, I think anybody who's been involved in it, which of course by definition everybody on this call has been, realizes that this is extraordinarily beneficial to everybody who is involved. This is not a one-way exchange of understanding, of learning, of ideas. It is always two ways. Certainly speaking for myself, when I worked as a doctor or teaching, for example, in the College of Medicine in Malawi, or in other countries in Africa and Asia, I was able to pass on some technical skills that were in relatively shorter supply at that stage. But I also learned a huge amount from my colleagues, which has benefited me for the rest of my career. And learn things about approaches to patients, learn things about how you do healthcare with more limited resources, learn things about obviously diseases and particular approaches. So I've always seen this, and I know that this is central to the philosophy of THET as something which is massively beneficial to everybody who takes part, whichever country they're in. It's a learning in every direction. And I think it is notable that if you look at the healthcare leaders, and I look at the healthcare leaders who I admire around the world, the great majority of them will have worked at some point in their careers in other countries or with people from other countries. This is a very central part, I think, of someone developing their own skills as well as passing on information and skills to others. So I do think that this should be seen as an absolutely central part of something which all healthcare workers should aspire to. Wherever they are based. Obviously, the way they can do that, the resources available are going to vary, but the general principle that we learn from one another internationally, I think, has to be right. And this includes very specific technical skills. It certainly includes approaches to medicine and how healthcare is delivered. And also, importantly, and THET, of course, has also supported this, it includes research. And I think one of the big learnings for people who are outside healthcare, I think people inside healthcare, of course, know this, is the extraordinary power of medical research to improve lives and to respond to new emerging problems. In the case of COVID, with absolutely extraordinary speed, but some things take longer. And we celebrate today, for example, the fact that yesterday WHO approved the first vaccine for malaria-wide rollout. This isn't going to be transformational; no one claims it is, but this is an important building on the work of very many African, Asian, and northern scientists at various stages along its pathway to achieve something which is going to have a very significant impact on top of all the other things that people are doing. So these are just examples where people's technical skills, the patient accumulation of information, the patient accumulation of research over years can have a transformational impact. So I think there's very many things to celebrate on that, and THET has been central to many of them. I could go through at this stage commenting on, with enormous admiration, the multiple things that THET is doing in different countries. I think I will probably limit myself just to two. One entirely self-indulgent, which is I'm so pleased to see the work, for example, that THET's been doing in Korle-Bu on burns in Ghana. And the reason I've highlighted that is my grandfather was chief surgeon at Korle-Bu, and my grandmother set up the maternity unit there back in the 1920s. And just to see the extraordinary development that Ghanaian doctors, nurses, and healthcare workers have achieved over that period is very remarkable. Going back to Korle-Bu from time to time, which I've had the privilege of doing, is a very positive thing. And then the other is a country which I've spent many years of my life, Malawi. Much of the work you're doing in Malawi, again, really transformational that has been achieved. But I'd also like to note, without wanting to go into any greater detail, the fact that healthcare workers in THET have worked against a background throughout THET's existence of difficult political environments. And I think, you only need to read the newspapers to know that working as a healthcare worker in Myanmar or in Ethiopia at the moment, in Somaliland at various points, has been a lot harder than it is for healthcare workers working in more settled areas. And that's added a double difficulty for the healthcare workers involved. And yet people have not only provided healthcare, but they have striven to actually improve healthcare, improve their own development, teach others who come and work with them. So it has been an extraordinary ability of people working with THET to work against very difficult backdrops and still improve the healthcare that's provided for citizens around them. Two final things, one quite brief, but it's just to acknowledge the importance I think there is of partnership between organizations as well as between individuals. And as anybody who has worked in lower income settings is aware, it is often the organization that struggles and has the difficulties. The individuals are often outstanding, but working with more challenged organizations. And organization to organization partnerships, I think, are an important part of what THET has offered to the system as a whole. Very important as a thing to achieve. And that includes across specific things like antimicrobial resistance, but it also includes organizational issues and just basically the delivery of healthcare more generally. And finally, just a few reflections on where health is going. Over the THET's existence, if you look back to what the healthcare challenges were in Africa, Asia, and Latin America, particularly Africa and Asia, when THET was first created by Eldred, they were overlapped with the problems we have now, but were quite profoundly different, actually. And that is because of the extraordinary development that has occurred in virtually every country in Africa and Asia over that time. And the age at which people have their biggest health issues has moved up over time. There's been an increasing emphasis on non-communicable diseases, always an issue, but increasingly so. But the communicable diseases have not gone away. There has been an improvement in technology, the rollout, for example, of rapid diagnostic tests, as the chair mentioned at the beginning. More recently, things like better communication between nations that allows us to have conversations without having to get on a plane and do all of those kind of things, which I think is a huge benefit. It has some limitations, but huge benefits. And new things like ultrasounds and new medical techniques, and remarkable changes in drugs and preventive treatments. Look, for example, at malaria, I mentioned that on the vaccine. Since 2000, roughly 50 to 60%, depends how you count on it, reduction in mortality from this major killer of African children. And that's a combination of better healthcare and better delivery of public health and better science. THET has contributed to all of those, and I could repeat the same over multiple other conditions. But right from the beginning, and at a time this was not fashionable, THET has also championed the importance of non-communicable diseases. Some of them rarer ones, but also the ones where, in a sense, the disease burden is heading now over time. So the ability of THET and the healthcare workers who work with THET to respond to new challenges is, I think, actually really central to its success over time, and I'm very confident it will continue. One of the advantages THET has is a disadvantage in other ways, but it's a big advantage in this, is it is a relatively small organization led by people who really do understand the subject. And therefore, the ability to change direction as the need changes is, I think, more flexible and much faster. That has been faster on its feet than I think many larger organizations, which take a lot longer to respond to changing need. So I really just wanted to close at that point with great admiration for what Thet and all of you individually have done in every country you work and whichever countries you move between or interact between. With considerable confidence that your work will continue to improve healthcare around the world.
Thank you very much, Chris. I have to say, Chris, my admiration for you soars, and I hope you can see all the claps and the hearts. I've never seen this before on the screen. It's brilliant. All the claps and the hearts rising up at certain points when you're going through. So I think everybody is, look at that. Everybody is incredibly impressed, and thank you for the words about Thet, which of course is an organisation we're passionate about. So thank you for those words too. We're going to come back to Q&A at the end. Can I remind people, if they want to, while they're thinking, put questions on the Q&A, please do, and we'll come back to them when we do the session at the end. Okay, I'm going to go on to our second speaker, and Chris has done the link incredibly well, Louise, for you. So our second speaker is a very valued member of the Thet team. Louise McGrath is Director of Programmes. Nobody is probably better placed to talk about resilience and solidarity in the difficult times. And when you talk about flexibility, Chris, Louise is one of the people that keeps that in mind. So Louise, I'm going to hand over to you with great pleasure, and want to hear what you say.
Well, thank you. And thank you, Chris, for that really enlightening presentation to start us off. And it's just such a great pleasure to be with you all today and to have this opportunity to shine a light on some of the incredible transformations and achievements of the health partnership community over this recent period. And I think a presentation should be coming up shortly. I think, yes, here we go. We can move on to the second slide. Charlotte, thank you. So as many of you know, health partnerships, those partnerships between UK and lower and middle income country, or LMIC as we often say, health institutions have been working together for many years to find ways of addressing the priority health system and health workforce issues that they face. And from Thet's perspective alone, we're aware of over 200 health partnerships working in over 30 countries on a myriad of health themes. And solidarity and resilience sits at the heart of the health partnership model. And that can be seen across the principles of partnership, which are on the screen before you. And most health partnerships begin by interpersonal relationships between health workers that then develop and flourish into long-term sustainable relationships between institutions. And as Chris said, that institutional relationship is really key to trying to ensure that change is made and is sustainable. And we know, and again, as Chris highlighted, that the benefits are accrued not only by the LMIC, health institution and health workers, but also by those on the UK side. Next, please, Charlotte. However, as we know, there have been a whole range of shocks that have affected many of us in many ways, but also the health partnership community. So with the occurrence of COVID-19 obviously impacting on all of our lives, all of our work, there were concerns to begin with that this would have a very serious impact on the ability of health partnerships to continue their activities. There has typically been a reliance on some international travel for health partnership activity, and that obviously became impossible. And also because of the tremendous strains on the health workforces in both the UK and the LMICs, there was a question as to whether anyone would be able to focus their attentions on health partnership activity. But we have seen really tremendous solidarity, as has also been highlighted, that across the health partnership community in both the UK and the LMIC, people coming together to try and find solutions that will work in both contexts. And we've seen the really rapid adaptation and innovation of the health partnership community, finding both new ways of working, obviously having to adapt to working online, but also focusing on new themes and topics. So that has included things like providing COVID case management training to frontline health workers through virtual means, and also things like supporting the local production of hand gel, which has then also benefited back to the UK because that same approach was then used in the UK. From THET's perspective, we've been very pleased to be able to secure some funding to support some of this activity. And we've also increased our presence in virtual spaces. So that's through things like the Pulse platform, which many of you hopefully are already members of, but also by opening up virtual volunteering opportunities, and also by things like this conference now being a virtual event. And we have also been working to develop some standards to support the use of technology in health partnerships. There have, however, been some unexpected benefits from some of these changes that have come about. And one of the most important potentially is by the inability of the UK partner to travel, we have seen in many instances a greater leadership role of the LMIC partner in the delivery of project activity. So a real shift in the balance of power and leadership in some of those instances. And also through things like virtual volunteering and online conferences, this has really increased the engagement of both health workers and partnerships as volunteers or to be participants of events like this one. Next slide, please. Of course, there are other shocks that have affected the global community and the health partnership community in particular. The coup in Myanmar. So on the 1st of February this year, a military coup took place, as I'm sure you're all aware, in Myanmar, an event widely condemned by the international community, including the UK government, and an event which has resulted in the shattering of the health system and health services in Myanmar, with a large proportion of the Myanmar health workforce unwilling to work within a system under the control of the military authority. We've been outstanding. We've been really so impressed by the outstanding resilience and adaptability shown by the Myanmar health workforce by finding new and different ways of responding to the healthcare needs of the population, even when that's involved stepping out of their core areas of expertise and when facing intimidation and threats of violence. But I think what we've seen that even though this has resulted in interruption to the formal health partnerships between UK and Myanmar health institutions because of the coup, those relationships between health workers have persisted and in many cases strengthened. And we've seen, there were some spontaneous acts of health workers and health institutions in the UK, and in particular the diaspora playing a really key role here, spontaneously seeking ways to support their peers, trying to provide new and different services in settings that they were unfamiliar with. And this, very quickly, THET was able to support the convening of this community of health workers and health institutions on the UK side, and which has included royal colleges, it's included academic institutions, it's included hospitals, it's included a whole range of institutions, GPs, so many health workers and health institutions that are involved in this community that's now been established. And as a result of this, we're seeing some tremendous advances in some of the steps to support health workers in Myanmar. And this has included, for example, the establishment of an online portal where numerous resources, guidance, tools, protocols have been made available and adapted to the Myanmar context. And that site, as it currently stands, has over 5,500 active users. And this is only one of many, many activities and strategies that have been applied to try and support peers in Myanmar, including some direct training to particular cadres of health workers. That includes the GPs, who are playing a key role in providing services in the community, and to the nurses, who are now in many cases returning to their home communities and in many cases the sole source of healthcare in a community. So there's a group of an ever-increasing group of nurses who are benefiting from support from the UK community. And hearing from Judith this morning, there are over 800 nurses who are now engaging in some of that training, and there have been over 40 hours of training. And I think what this mechanism has shown us is that the bringing together of the community in this way has not only facilitated the coordination and joint working between health partnerships, and it's really shown some tremendous efforts across the health community, but it's also helped open up and strengthen linkages with other sectors and other sorts of institutions who are working to support the Myanmar health workforce and build their resilience. And that includes national and international organizations and news and media outlets. And this has really been such a strong example for me. I mean, we have bi-weekly meetings, and over 40 people are typically in attendance at those meetings. And it's a constant reminder of the solidarity between health workers and what can be achieved by coming together to work together on joint aims and objectives, and a real demonstration of that power of partnerships to achieve more than the sum of the parts. Next slide, please. And the third major shock that has affected the health partnership community is the cuts to the UK aid budget. In terms of funding that was due to be awarded to health partnership activity, that's been over 40 million of funding that's been cut, which has obviously had a huge impact on health partnerships who had been working together to develop responses to address the priority health workforce needs in their countries. In some cases, we know this has resulted in the reduction in the ability of some health partnerships to respond to new opportunities as they've had to downscale. However, there are some positive signs on the horizon. So THET's been lucky to be awarded some short-term funding to support some of those health partnerships that were due to be funded through the UK Partnership for Health Systems programme, and we're continuing to seek other opportunities because we're so convinced of the value of this model that we're going to be championing the cause long into the future. Next slide, please. And just some reflections across this period. I think what's been clear is, I think the transformation we've seen during this period is probably one of the biggest and most rapid transformations within the health partnership community in its history. That's been underpinned by the solidarity and made possible by the solidarity between health workers, which is such a core component of health partnerships and has really helped to galvanize that effort to try and make a difference in the face of the challenges that we've all been facing. This has contributed to the resilience of the health systems and the health workforces involved. And I think, as I say, there are a number of benefits that these changes have also brought about. We've talked about the benefits to the balance of power within health partnerships and the increased leadership of the LMIC partners, but also the increased engagement and accessibility of some of these activities and events as a result of being virtual. But we mustn't forget the key contribution, the key benefit to the climate that the reduction in international travel is also bringing about. So really, helping us focus on what we can do to not only deliver better health partnership projects, but also reduce our impact on the climate. We know there are a number of challenges still ahead, and obviously COVID still continues, and particularly in many of the countries where we're all working, whilst also in the UK, but also in Myanmar, etc. However, I think what the last 2 years has really shown us is that we have every reason to be confident that there's a very strong and key role for health partnerships to play in addressing the health system and health workforce priorities that are before us. And just to finish on the last slide, I wanted to echo the thanks and the celebration that Chris has mentioned, and say a very big thank you to all of the health workers and the health partnerships that have worked together in such challenging times to find new and innovative ways to address the priorities and challenges before them. So thank you, everyone. Thank you.
Thank you very much, Louise. That was it's always nice to have it said, isn't it, Louise? We know the work that it does, but even for me, it was lovely to see it all presented. So thank you very much indeed. And it is that celebration of the health professionals, which is so important, very uplifting. Again, I say questions, please do put them in the Q&A session and we will come back to them at the end. I'm going to introduce Chris. Well, Chris Carter is another nurse. So I'm saying Chris, I'm very, very proud to introduce Chris, who's actually in Zambia at the moment. So let's hope the Wi-Fi does continue to work. Chris is a senior lecturer at Birmingham City University and is a critical care nurse. And he's going to talk to us about really working challenging times. Chris has been trying to keep things going, all the challenges we've recently had. So Chris, delighted to hand over to you. Over to you.
Thank you very much. Thank you for inviting me to present this morning. I am just going to try and share my screen so I can, hang on, I've lost the, so I'm just going to share my presentation, hang on, and then we can, then I can start. So this morning I'm going to talk about my experiences of working in the pandemic as a critical care nurse in both the UK and in Zambia. So hopefully you will see my slides now. I think that you will agree the settings are very different in Zambia and the UK, but in both countries, COVID has impacted on some of the most vulnerable people in our communities. And in this presentation, I've used some quotes and photos which I've been given permission by my Zambian colleagues to use so that I can share with you what it has been like over the last 18 months. But I'm going to start by explaining my dual role. So during my first visit to Zambia in 2015, I was actually funded by FET to undertake a scoping visit. And when I visited, I met Esther, who you can see in the picture, who was the nurse in charge of a critical care unit. And she made a very strong impression on me because against all the odds, she was leading a team of newly established critical care nurses. And she told me her dream, that she wanted to see critical care nurses have an opportunity for career development and to have more opportunities. She recognised that while short training courses and workshops were good, the nurses never get opportunities or chances for long-term education programs like the doctors. Yet the nurses have to do a bulk of the work at the bedside. Sadly, as you can see in this slide, Esther never got to see her dream. But I am proud that I've listened to her and the other nurses I met during that trip, and I've kept my promise to do my best that I could for them. So since then, our partnership has focused on developing a specialist practice, a national career structure for nurses, context-specific education programs, and raising the level of education from diploma to graduate level. And just prior to the pandemic, in February 2020, our partnership conducted our second national workforce review. And you can see the map here, which shows you the hospitals that we visited.
Chris, we can only see the overarching screen. Can you go on to actual slides?
Oh,
sorry.
Right.
For your sake. That's, yeah, okay, because we're not, great, thank you.
Okay, so you can see here in the map, this was the hospitals that we visited during that national workforce review. And we looked, and that involved visiting 5,000 kilometers, undertaking a 5,000 kilometer trip in 10 days. And we had a really clear plan and understanding of how critical care, emergency, and nursing midwifery workforce was functioning in Zambia. And we had a clear plan on where we were going to go next as a partnership. We'd heard about this virus that was in China, but we weren't sure how it was going to affect us. So when I returned to the UK in March, we had our first wave. And where I lived in South London, it was the epicenter. And like many nurses, I immediately volunteered to work overtime as a critical care nurse. And I was then seconded to become a matron of an intensive care unit in London for about 4 months. And I can truly say I have never seen anything like it before, and it will stay with me forever. Part of my role was to rapidly set up training programs, to work clinically to support staff redeployed, and to expand the critical care unit to respond to the unprecedented number of patients. But it was also challenging to hold down a clinical job, continue my university role, and then continue to work with partners virtually, meaning at times it could be quite overwhelming. But I knew I had to carry on. And on reflection during this period, although it was difficult, I do think some of the skills, ideas and resilience I learned working in Zambia and other countries over the years certainly helped me during this time. Having seen the devastating effects of COVID-19 firsthand in the UK, I knew my colleagues in Zambia were going to have it tough. We'd had numerous virtual partnership meetings, and we knew the fear and the anxiety that was coming when they would have their first wave. So my colleague and I took the difficult decision 5 months after the start of the pandemic, with full support of our partnership, Birmingham City University and the Zambian Ministry of Health, to return to Zambia. Our main argument was nursing is a competency-based profession, and virtual learning alone doesn't teach competence. We had difficult decisions to make. To provide context, emergency and trauma nursing is a relatively new specialty here, and it only started in 2018, and so only 2 cohorts had completed training by the start of the pandemic. Critical care nursing is less than a decade old, and as we found in our survey just before the pandemic, many of these staff, these healthcare workers, are working in facilities across the country, and they're the only specialist staff available to respond to the demands in the hospital. So we had to find ways to help them cope, as we knew these nurses were working in isolation and needed to respond to COVID-19, but everything else that they still had to deal with within the healthcare facilities. We also recognised early on that COVID-19 would leave short, medium and long-term issues for this already overstretched health service. So our response was to support the immediate needs, but also plan how we could future-proof for when things got better, so that the hard-won gains would not be lost. Before the pandemic, there were many activities, and when we arrived back in September, we found that many of the partnerships had moved to virtual activities. So our partners were pleased that we'd come back to be with them, and they called us our all-weather friends, and it's a term that they still use to this day. But often we found that there was a real need for practical competency-based training, and requests from healthcare facilities started to come in on topics such as infection prevention control and oxygen therapy. One of the biggest anxieties was the different use of oxygen in COVID-19, and they really wanted to know what to do for the best of their patients. A challenge for us was we are nurses, and suddenly we were teaching doctors, clinical officers, general nurses, physiotherapists, pharmacists and medical students. And for us in the UK, interdisciplinary teaching is accepted and normal. In Zambia, nurses teaching doctors is unheard of. So a lot of our trainer-trainer activities was about building not only competence, but confidence in the training teams. There were huge challenges. When I think back to this time and to the timeline, the work that we're doing now, when you're trying to cover everything, it's tiring and draining. It's been relentless at times because I've been working here on my own for some of the time. We've lost many colleagues and friends here, and listening and supporting staff as they tell you about another colleague or family member has been tough. You don't know who's going to be next. And I have to say, it has been challenging to see some of the realities in practice and trying to provide support. We've also focused on not just COVID whilst we've been here supporting our partners. We've taken the advantage during the drop in cases between the waves to try and maintain other activities in order to improve specialist care. So here you can see we've had virtual volunteering with lectures being delivered to nurses and other healthcare workers, and you can see here a colleague from the Royal Free in London teaching sepsis. Through our Health Education England volunteer bursaries, we supported a neonatal nurse from Manchester to capacity build to provide capacity building activities for the neonatal course and the neonatal intensive care unit for 6 weeks. We also supported a citywide trauma training package, which culminated in a major incident exercise, which tested the pre-hospital response, but also the emergency preparedness and hospital response to dealing with a major incident. COVID has been traumatic, but somehow we've managed to keep our sense of fun, and we've had some good times when we can. We've had many successes in our project, and we've started to see that actually some of the work that we started early on in the pandemic are now starting to come to fruition. We've supported over 1,100 healthcare workers to have completed our COVID-19 training package, and we're now in the process of delivering more workshops throughout the country before the predicted 4th wave. We've started to see some of the work that we did prior to the pandemic come online, so we're now investing in the future healthcare workers that will be needed in future waves and to provide sustainability. When I first came to Zambia, there was just one college of nursing and one lecturer. 6 years later, we have 3 colleges of nursing and 3 Zambian nurse tutors delivering critical care courses. The work we commenced in 2019 to support the development of a Bachelor of Critical Care Nursing was implemented in September 2021. And we've also supported a revised emergency and trauma curriculum to support the changes in practice and to recognise how to respond to infectious diseases. Birmingham City University has also supported the priming of 20 Zambian students through a UK clinical masters programme. And these students are leaders in practice and education, with the hope that we will be able to maintain sustainability in the future for all of our work. So finally, looking at this slide, it sums up what my time in Zambia has been like. You can't do it alone, and you need to work as a team, and you have to be part of the community. It has been humbling to have been welcomed, accepted and trusted regardless of the risk. It has been a tribute to the healthcare workers here who keep going to work without adequate PPE, vaccination, and then taking huge personal risk day after day. I certainly have been proud and honoured, and it's been a privilege to stand alongside such immense healthcare workers in both Zambia and the UK. And our partnership is stronger, and we will continue to work together. So thank you very much.
Thank you very much, Chris. I'd say the pride for you and your Zambian colleagues just shines through. And I think it brings to, as you say, the all-weather friends issue, which again was interesting, going out to areas that had Ebola during that. It's always that you don't abandon us issue, and I think that comes through really well. I'm going to start the questions, and Chris, while you're there and waiting, I'm just going to deal with 2 of the questions. Audrey put a question in about the issue of competence, etc. I think you probably answered some of it, but you mentioned resilience. I'll read the question. You mentioned resilience. Do you think working in partnership supports any of the 7 building blocks of resilience? Competence, confidence, connection, character, etc. Thank you for putting on screen. So, Chris, do you want to just deal with that question, because you did cover some of it as well?
Yes, I mean, I do think sort of working in a partnership definitely builds all of those 7 blocks of resilience. I think from my own personal experience, it's seeing things done differently, getting different perspectives, understanding, why things are done in certain ways. And I think you sort of, that does open you up to different ideas, which certainly can help build your own coping strategies, your own confidence, and also hopefully help you build your competence as well. So I think certainly, yes, definitely for me, working in Zambia and in other countries, definitely I think it can help support resilience. And because I think when you work in a resource limited environment, you sort of see the challenges continuously, and that's where you might get different ideas and you talk through and get different perspectives.
Okay. Chris, staying with you, one of the things that's been troubled is the question that we have about travel. So Lisa's question, what would you say to health partner community colleagues who are anxious about restarting travel? We've had this a lot, and I know you debated very carefully before you returned to Zambia. So again, can you have a go at reassurance?
Yeah, I would say, I mean, it was a difficult decision, and we certainly discussed it, and we took advice from lots of different areas within the university, and we also at the time were working with VET, so we certainly had conversations with VET as well. And for us, it was about the risk assessment, so making sure that we did a robust risk assessment and understood the risks as much as we could have, and certainly the university understood the liability and the risks associated with that activity. But I think it also comes down to understanding the context in which we were going to work in, and the strength of the partnership. And we certainly had those discussions with our partners as well to sort of say, these are our concerns. What's your perspective on this? Can you advise? And so for us, it was very much a collaborative discussion and communication. But we certainly have got processes in place should things go wrong, or we certainly have sort of tried to sort of mitigate the risk as far as possible. And so we have an ongoing risk assessment and regular reviews where we sort of reevaluate the situation.
Which is that risk planning very carefully, isn't it? Can we, if we stick to a sort of similar theme, if we go to Lisa's question, to Professor Whitty, really, how can we encourage senior managers and leaders across the NHS to support their colleagues in engaging in global? So we've gone from Chris's answer of getting people in that security and risk. Chris, can you help with this question? Chris Whitty, we're on there. Is he still there, or has he gone? I think he might have had to go. Okay, so in that case, I'm coming back to you, Chris Carter. You're the person who's in the NHS. How do we encourage?
I mean, for us, I mean, we do use virtual volunteering. So we use that as a way to try and maybe provide opportunities for people to engage in global health. And certainly our faculty has been built up from people from across the NHS. And some of the conversations we've had with senior managers and leaders, particularly on the nursing side in some of the hospitals, have been around that they see this as a recruitment and retention opportunity to provide something different for staff. And that's certainly because it's been, I think, so relentless in COVID, and actually something a bit different that maybe the managers are willing to support and give time to do, so it's a bit of like it's an opportunity to do something different. So we've sort of found it quite positive to engage with senior managers, particularly in the nursing structures, who've supported staff to do with our virtual volunteering, and then we're hoping that will provide us with a pool that we can then use for actual activities out here when maybe the international travel improves and we can get more flights.
Okay, Louise, you got to come in.
Well, just to add, I think there's a challenge to us all to really ensure we're continuing to take every effort we can to gather evidence of the benefits, so that we can then use that to encourage managers to see the value of engaging in global health. So that's a challenge to us all, but one that we're keen to work on together across the health partnership community. Thank you.
Great. Louise, can I stick with you? Can we answer Prinko Kazadi's question, which is a difficult one, but I think, Louise, can we have a go at seeing how we can help? So this is DRC have 600,000 patients with epilepsy, but only 2,500 patients are under treatment during the COVID-19. How the partnerships can help to reduce this challenge? Such a difficult question.
Yes, that is such a difficult challenge. I think obviously there are key issues around what is the existing level of the health workforce that can engage in providing that care. What are the challenges that are preventing that? Is it that the services aren't there? Is it that the the health workforce isn't there. But I think from an analysis of what the problems are, we know across the health partnership community there are organisations working on similar themes in other contexts, and no doubt others that are keen to engage. So I think this is a question that could be put maybe on the Pulse platform to see if others are working on this theme and can make some suggestions or offer some support and advice. So I'm not sure whether you're already on the Pulse platform, but I would suggest, I'm not sure if a colleague can put the link to the Pulse platform in the chat. But I think we're keen to facilitate making connections so that where there are needs and areas of expertise that can be shared, we can help to facilitate those linkages. But it is a major challenge.
Now, the next question is really difficult. This is from Neil, and in a way, it's a shame that Chris has gone, because we've all know the problems with ODA budget. We know very well how FET has had to sort this, and in fact, sympathy goes to our partners where funding was withdrawn from some of the projects. Can you try and answer Neil? Neil, I know, understands this world well. I don't. It's a shame we can't have Neil helping us answer as well. But if you could have a go, that'd be great.
Yes, and again, another nice challenging question for me here, which no, it is a key issue. I mean, we have seen that without funding, health partnerships will find ways of responding as far as they can. So I think the Myanmar example is a very strong example of that. Without any initial funding, we have since been able to secure some funding to support some of that activity, but without any funding, people came together and were wanting to see what they could do, and above and beyond their job roles were engaging in activities to support their peers. That's only sustainable up to a certain point, of course, and the need for institutional support is normally required to enable that to be sustained and to ensure that coordination and that the due process is followed. So I think certainly alternative ways of engaging. So I think the virtual engagement can offer some reduction in costs, but there is still the need for some funding for some health partnership activity to enable it to work effectively, I would say.
Yeah. If I just allowed to comment as well, Neil, I think the other thing we've seen is that the relationships that have developed over many years, this is again this all weather friends. The bad weather for us has been some of the withdrawal of funding. But in fact, those relationships have persisted. And in fact, technology has helped us. So a lot of us, although there's no funding, that interaction between, and what that has meant is as we've managed to get funding, we've managed to re-kick at the start some of those projects. But it is a massive issue. And we all wait with bated breath to see what happens in the next 6 months. Because the partnership is still strong because of people. But the funding for the activity is not there. So I think it's that sort of balance, really. Sorry, I just thought I'd help a little. Right, there's another one for you, actually, Chris, from Dorcas Guata. Chris Carter, did you observe any mental health needs in staff working in Zambia, and any lessons for us in the UK?
So, yes, definitely. I mean, in Zambia, they also had a staggered wave. So when we had our first wave, they were sort of, their first wave was like 2 or 3 months later. So, so definitely there was a lot of fear and anxiety. And as they went through their first, second, and third wave, certainly the number of cases went up, and you could see the anxiety. And certainly we've done some focus groups, and we've had a national survey running on nurses' experiences of COVID. So we've certainly picked up that there is mental health. There's also stigma around healthcare workers going to working in COVID centres and then the field bringing it home. One of the things we've mental health, is a stigma here. So one of the challenges we've tried to do is we've tried to put in like the well-being aspects into all of the trainer aspects. So there is always an element of mental health first aid added to the trainer programs, and then the cascade training with signposting. I think the lessons for the UK is it's about making sure the resources are there to signpost. I think here we've tried to sort of signpost within the resources that are available within the Ministry of Health, but also the support mechanisms within the hospitals as well. But I'd say it's certainly an area that I think we are trying to address, but I think it's an area that we we're going to have to focus on a lot more as we continue with our work out here.
Louise?
Well, I just wanted to add a point that it's a slightly tangential point. But one thing we're looking into at the moment is what role can the engagement in health partnership activity in global health play to support the well-being of health workers and build that resilience. So there's an inquiry that we're in the midst of at the moment, and there are some sessions during the conference that will be picking up on that theme. Thank you.
Great.
Just to say, sorry, just to finish up, we did have the Health Worker Action Fund right at a grant right at the start of the pandemic, which sort of was, to try and do that short-term sort of capacity building in that area. And we certainly sort of used virtual volunteers from we had some doctors from South London and Maudsley NHS Trust, and so they certainly helped us to sort of start some of the work off. So we've used sometimes virtual volunteering in that field to try and help develop our expertise. It's not our necessarily expertise in that area.
Great, thank you both. Just for Priyanka Kazadi, Dorcas Squash is saying that they have done some work in epilepsy in Zambia, and she's going to make sure she contacts you so she can do that through the conference. Dorcas, thank you very much. That would be, it's in Zimbabwe, I take it back, but work in Zimbabwe. So Dorcas, that would be wonderful. Thank you very much indeed. I think if we just go, sorry, I'm just scanning my questions, which takes a time. Chris, can you put your Ask Again hat on? See if you can help a bit. Sorry. This is from Senegal. How newly hired overseas nurses around the globe in the UK is really helping the NHS or UK healthcare gaps? Now, go for it, Chris.
Okay, thank you for that question. So with my RCN hat on, I do sit on the RCN International Committee, and the UK diaspora is certainly an area that we've been focusing on over the last year or so, and they have now established a working group to actually see how we can support the UK diaspora in the NHS. And there is, I think, the RCN actually hosted a meeting with representation from nursing organisations in the UK, and they're looking to take that forward to make sure that the representation, acknowledgement and support is there. So that work is in progress, and that is being chaired by, the working group is being chaired by Professor Catherine McCaw, who is the President of the Commonwealth Nursing Midwives Federation, and also Felicia Kwaku, who is also on the RCN International Committee and based at King's College London. So certainly the RCN is picking up on that, and there'll be more information to follow on that.
Just for people overseas, the Royal College RCN is the Royal College of Nursing, and it's the Nursing Association for the UK. I think they've got something like, 48,000 members or something, so it's a very large organisation. Louise, do you want to help with some of the work that's been doing about
Yes, I was just going to highlight a new report that we've recently launched, Experts in Our Midst, looking at the role of the international health workforce and diaspora workforce in the NHS, both in terms of the contribution they make to the delivery of health services in the UK, the challenges they face and how some of those need to be overcome, but also the role they can play in global health partnerships with their knowledge and awareness of health systems and other contexts. So I'm hoping a colleague will share the link to that report in the chat as well. Thank you.
Okay. I'm going to put it close. We've got about, so many seconds left. So just to say thank you very much to the two of you. So that was great. And obviously thanks to Professor Whitty, whose time is tight. So I do understand that he had to leave us. But thank you very much. Good chance for the questions. We've answered most of them. I think it was just one or two left. So thank you for the session. I think we're now going to a break where everybody can start to decide what they're doing next. So thank you. And again, welcome to the conference. Thanks very much.
Thank you. Bye.
Bye.
Thank you.